I welcome you all for today's webinar, Advances in Breast and Gynecological Cancer Management. With immense pleasure, I would like to invite Dr. E. Prasad, who is Senior Consultant Medical Oncology at Apollo Proton Cancer Center, Chennai, for the welcome and introductory note. The stage is all yours, sir. You can start.
Yeah, thank you so much for the kind introduction, and thanks, Glenmark, for the sponsor of this academic session. So this is going to be a interactive discussion between the various medical oncologists in the state of Tamil Nadu, along with the diagnostic modalities, which is taken care by the Unipath, the session done by Unipath Laboratories. So this will be a session on management of gynecological cancer and breast cancer. So this would be the session for the today, and I invite the speakers, Dr. Armugam, who is the medical oncologist and associate professor of medical oncology in Tirunelveli Medical College. Dr. Armugam, welcome, sir. Dr. Prasanna, who is the senior consultant in medical oncology in Apollo Specialty Hospital and Cancer Center, Tiruchirappalli. Welcome, Dr. Prasanna. I welcome Dr. Pandidurai, Associate Professor and Senior Consultant Medical Oncology, Government Rayapeta Hospital. Welcome, Dr. Pandidurai. And welcome Dr. Raja, Associate Professor, Government Rayapeta Hospital, Dr. Rai Memorial Hospital, Senior Consultant in Chennai. So welcome all senior consultants and speakers for this today's session. And I welcome all the audience as well. The session is open for the discussion today. And I welcome Unipath Laboratories for their support and inviting them to have this talk on diagnostic advances in gynecological oncology. What do they offer from the laboratory side as well? So I hope all my speakers are available today for the session. And we would like to start with the first session, which is the management of treatment naive advanced ovarian carcinoma. So are we good to proceed?
Yes, sir. Yes, sir.
Great. So the first session will be done by me. I'll be sharing my screen. So this would be the opening session on the management of advanced ovarian, newly diagnosed advanced ovarian carcinoma, and what are the newer modalities that are available at this point of time. It will be a quick run through of the various modalities of the treatment of ovarian carcinomas. So I'll be talking about the investigation, staging workup, what are the first line treatment options available, and I would leave the rest for the rest of my speakers. So a little more about the epidemiology of ovarian carcinoma, which is the eighth most common cancer and the fifth most common cause of cancer mortality. So every year, close to about 3 lakh women are diagnosed with cancer, of which about the 2018 had recorded close to about 2 lakh deaths. Europe has the highest rate of ovarian carcinoma, and the median age at diagnosis almost like 63 years. And the 5-year survival of these patients who are present with ovarian carcinoma is about 43%. So when we're looking at the Indian statistics, again, the incidence of breast, ovary, uterus, and cervical carcinomas are the most common cancers in Indian women. And when we are looking at the 10-year survival, we see that breast has close to about 76% 10-year survival, followed by the uterine malignancy, endometrial carcinoma, 72%. The survival for cervical carcinoma, all stages put together, is about 51%. And last comes the ovarian, 10-year survival is only about 35%. So overall, we know that the ovarian cancer survival or any other cancer, when it is diagnosed in a very early stage, the survival is better. And if the stage is very advanced, the survival goes down. And the 5-year survival for a stage 4 ovarian carcinoma is only about 14%. So overall, we know that most of the data for the Indian women is also on par with the global data. So these are the risk factors which are associated with the development of ovarian carcinoma. age, BRCA mutations, the incidence of ovarian cancer is close to about 60 percentage and 27 percentage in BRCA1 and BRCA2 mutation. Somebody who's on an hormone replacement therapy for more than 5 years runs a higher risk of developing ovarian carcinoma, prior fertility treatments, endometriosis, OCPs, parity, breastfeeding, tubal surgery, all are the risk factors for developing ovarian cancers. But why is that all the ovarian carcinomas are diagnosed in a very late stage? The main reason is early symptoms or signs absolutely are not very specific for ovarian cancer diagnosis. Especially, it presents generally with bloating, abdominal fullness, urinary frequency or pelvic pressure, which generally is considered as cystitis in women, fatigue, vomiting, and most of the time it is associated with indigestion, constipation, abnormal vaginal bleeding, back pain, or shortness of breath. So, when all these happen, they are already in a locally advanced stage. Most of the time, it is diagnosed as an irritable bowel syndrome or gastritis, and it never comes to the attention of a clinician. So, what are the diagnostic tools which are available? So, first thing is a history taking, transvaginal ultrasound if possible, if there's any suspicion, and blood tests, tumor marker, CA125 might guide. But CA125 may not be very appropriate because it can also be elevated in malignant conditions other than ovarian carcinoma, as well as it is elevated in other benign conditions also. So, how to evaluate? So, whenever the presentation to a general practitioner, the GP needs to assess the symptoms. A little more suspicion has to be there when there is a repeated presentation of similar symptoms for a patient and an immediate or an early referral to the multidisciplinary team, which consists of the surgical and the medical oncologist or the radiation pathology team is available. That would help in identifying the patient in a very early stage and starting with the treatment. So exactly when is the women needs to be referred as per the UK guidelines? If any of this following symptoms are present more than 12 times a month in a woman who is more than about 50 years of age, we need to look at a possibility of early referral, which includes persistent abdominal distension, feeling full or loss of appetite, pelvic or abdominal pain, increased urinary urgency or frequency. The patient needs to be evaluated with the serum 125 value, and with the serum 125 value elevated, patient needs to be evaluated in a higher institution. So why do we do not have any screening methodology for ovarian carcinoma? It was first evaluated in a randomized control trial in UK with more than 2 lakh women evaluated for the screening protocol. Patients were randomized to have ultrasound with CA125, ultrasound alone, and no screening. The primary outcome of ovarian cancer mortality was evaluated, and it was seen that the ovarian cancer screening with either CA125 or pelvic ultrasound did not lead to any early diagnosis. And you could see the ovarian screening survival were all the same with either doublet evaluation with ultrasound and CA125 or ultrasound or no screening at all. So this is the reason why none of the current screening modalities do recommend any screening for ovarian carcinoma. So most of the time, patients do present in an advanced stage where patient lands up with the gynecologist or the gynecologist where the surgery is generally done. Subsequently, adjuvant chemotherapy is done, and the patient would have a 15 to 18 months of symptom-free or a treatment-free interval, and subsequently relapse happens. More relapses happens with a lesser treatment-free interval, and subsequently patient dies because of extensive peritoneal disease. So with such a situation with repeated recurrences, with the invention of the newer molecules, we are looking at maintenance treatment after the first line treatment, which prolongs the treatment-free interval to close to about more than even 7 years. So this is specifically done with the advantage with the advent of the PARP inhibitors as we evolve to understand the molecular pathology. So similar to the lung carcinomas, we do have started to understand different gene mutations which are present in different histological subtypes of ovarian cancer as well. So the evolution of treatment of ovarian carcinoma had completely changed over the past 50 years. From single agent cyclophosphamide as the only treatment, now we do have a lot of drugs for different stages of cancer. But how do we choose the treatment? So there are a lot of key factors in the decision making, which would be the disease stage, histopathology, patient factors, renal parameters, and of course the age of the patient, which would be very, very important in deciding the treatment plan. Not just the patient factors, also the physician factor, which would include the presence of multidisciplinary team, surgeons, medical oncologists, clinicians, nurse specialists, pathologists, molecular laboratory, especially the involvement of the primary care team. So everybody would be the part of the ovarian cancer treatment. So coming to a little bit of the surgery, we do have primary surgical debulking if the disease stage is 2. And the primary intention of a curative surgery should always be to achieve a R0 resection. But most of the time, if R0 resection is not possible, then neoadjuvant chemotherapy has to be given. So how does the role of neoadjuvant chemotherapy come in? It is mainly to make sure that patients who had a complete resection do have a longer survival, but patients who do have a residual tumor of more than about 1 centimeter have a poor survival. So that's the reason why most of the time surgeons do refer the patients for a medical oncologist at least to have a good R0 resection when they take the patient for a complete cytoreductive surgery. So is there any change between taking up the patient for an upfront surgery or taking up the patient after neoadjuvant chemo? Absolutely, the overall survival is the same. There is no decrease in the survival data, but of course, patients are able to have a lesser postoperative complications if they are taken after neoadjuvant chemotherapy, and that has been proven in multiple randomized controlled trials. So overall, we do have this standard combination of paclitaxel and carboplatin. We do have these two drugs, bevacizumab, which was the first drug which was to be invented for the maintenance treatment, and that had shown to have an improvement in the disease-free survival based on the GOG study data as well as the ICON 7 data. So both the trials have confirmed that the patients do have an improvement in the progression-free survival, and the overall survival is improved in the high-risk population like stage 4 suboptimal disease resection, large residual disease or ascites. So when patients do have these problems, patients are considered as high risk and they can be started on paclitaxel along with bevacizumab and maintenance bevacizumab. So, following the NCCN guidelines, there were also a lot of Indian guidelines which had come up, and that has also recommended the use of bevacizumab in stage 3 and stage 4 epithelial ovarian carcinomas. So, overall, when we are looking at using paclitaxel and bevacizumab, close to about 70% of the women do have relapses within about 3 years of the first line treatment. By 5 year survival of stage 3 patients is only about 20 percentage, and when we are looking at 5 year survival of stage 4, even with the triplet regimen, it is only 5 percentage. Now comes the role of the identifying the BRCA mutation patients. Again, we will have a detailed lecture on the BRCA mutation and the testing from the Unipath laboratories. So now comes the role of HRD assay. Again, HRD assay helps us to choose the right patient who may be a candidate for further maintenance treatment with first line PARP inhibitor. So we do have HRD positive group, HRD negative group. In HRD positive, we do have BRCA positivity and tumor BRCA positivity or patients who do have high genomic instability score of more than or equal to 42. So we do have all these Indian data available for our patients, wherein we can use these data for choosing the right medication for the right patient. A little touch on the solo trial. We do have the use of adjuvant olaparib versus placebo, which was initially evaluated in solo 1 trial for a period of 2 years. we could see that the progression-free survival had improved to close to about 60.4 compared to 27 percentage, and that has also turned into a overall survival advantage. So patients who have a BRCA mutation and who were treated with olaparib did have an improvement in the overall survival as well. So we do have these options of giving olaparib as a monotherapy, olaparib with bevacizumab combination for patients who have non-BRCA mutation but HRD positive with a high genomic score. Not just with olaparib, we do have a data Athena mono trial in which rucaparib is identified as to have a better PFS as well as OS advantage, and we don't have niraparib, but all these medications are approved in the NCCN guidelines as the primary post-primary chemotherapy maintenance regimen. So thank you so much for your patient listening, and I would invite my next speaker, Unipath Laboratories, to deliver the talk on diagnostic advances in gynecologic oncology. Over to you, sir.
Yashika, madam, can you have the next presentation, please?
Yeah, sir, am I audible?
Yes, yes.
Okay, so we are next speaker is Dr. Pandi Durai, right?
Okay.
Sir, Dr. Prasad, can you please introduce Dr. Pandi Durai? He's the next speaker.
Welcome, Dr. Pandidurai, sir. Dr. Pandidurai is the Associate Professor of Government Rayapeta Medical College and a Senior Consultant in Meridian Hospitals, Chennai. And he'll be talking on the management of treatment-naive advanced ovarian carcinomas. Over to Dr. Pandidurai.
Hello. Hi, everyone. I'm audible.
Yes, sir.
Let me share the slides.
Sir, will you be presenting your own slides?
No. This
Okay.
slide is given by the team.
Okay. Okay, just give me a minute. I'll present your slides.
Okay.
So you can start.
Thank you. So I'm going to talk about the management and treatment of advanced ovarian treatment of advanced ovarian cancer. And first, next slide, please. So these are the subheadings under which I'm going to lecture. So we'll see one by one. First, DNA damage and role of PARP and BRCA. Second one is HRD testing, and next one is guidelines and recommendations, clinical evidence, the recent evidence, and conclusion. Next slide, please. Yeah, next slide. So in day-to-day life, there is a lot of stresses to the DNA, and the DNA got damaged every day. The cells are getting repaired, DNA is getting repaired. So in that we have a single strand repair mechanisms and double strand repair mechanisms, which are of our clinical significance related to ovarian breast cancer. So we'll see one by one. Next slide, please. So, PARP enzyme, which is a single strand break repairing enzyme. It is a base excision repair type of enzyme. It's considered, it has a part 1 and part 2. The protein consists of 2 ribose units and 2 phosphates per polymer unit. So this role of the PARP enzyme comes when there is HRD with a BRCA mutation. So when there is a defect in double strand break repair mechanism. So the PARP, when we inhibit PARP, this is called synthetic lethality, which results in the death of a cell. Next slide, please. So when the single strand repair fails, which is then converted into double strand repair, double strand break, then the double strand repair mechanism comes into play. That is the HR homologous repair and NHEJ, that is uh, uh, non-homologous end joining. So non-homologous end joining, we will see one by one in detail. HR homologous repair consists of BRCA1, BRCA2, and other genes. So there is an entity called non-BRCA HR also there. So it includes BRCA1, BRCA2, ATM, PAL-B2, BRIP1, RAD51, and CHEK2. So these are come under homologous recombination genes. Next slide, please. So this is the slide depicting pictorial depiction of the double strand and single strand repair. Double strand repair. That is homologous recombination repair, in which there is a complementary strand where sugars are added complementary to each other. It is very perfect repair. And the non-homologous end joining, it is a single base. Every time the single base is synthesized and incorporated, and it is prone for very errors. High risk means high probability of errors are there. Next slide, please. Yeah. So these are the inheritance of the BRCA. BRCA is dominant patient. BRCA1 and BRCA2 are inherited by a dominant patient. Next slide, please. So these are the clinical significance. So the breast cancer in BRCA1 and BRCA2 is around 50 to 65% and 40 to 55% respectively. The ovarian cancer is about 40 to 65% in BRCA1 and 15 to 25% in BRCA2. So there are other cancers which include prostate and pancreatic cancer, which are clinically significant, and we test BRCA in these cancers. So next slide, please. So this BRCA1, BRCA2 deficiency leads to a defect in DNA repair, which leads to chromosomal instability, and there may be some increase in gain of oncogenic function or loss of tumor suppressor function. So BRCA itself is a tumor suppressor and gene. So this lead to the phenotypic exhibition of the cancers. Next slide, please. So there is a there are you all know that is germline and somatic mutation. So somatic mutation changes cannot be inherited; it is acquired during the life. It is present in the single organ and it can lead to cancer. And germline is DNA changes inherited. And it increases the cancer susceptibility. The germline DNA change, because it is inherited, is present in every cell, including the reproductive cells. So it is passed from passed to next generation. Yeah, next slide. So for somatic testing, we have to take the tissue of interest, that is the tumor tissue. And for germline testing, we have to take blood or saliva. So next slide, please. So next is the HRD testing. So HRD can be assessed by two different biomarkers. In ovarian cancers, these include individual mutations, BRCA1, BRCA2, and the assessment of genomic instability. So HRD testing includes loss of heterozygosity, LST and TI, and can inform prognosis and treatment decisions. Next slide, please. These are the indications for BRCA testing in the breast and ovarian and pancreatic cancer. So when you see a triple negative breast cancer and or multiple primary or maybe asynchronous somatic and lobular breast cancer, we have the BRCA test is advised as per NCCN guidelines. So in relatives less than 50 years who have breast cancer or male breast cancer, ovarian cancer, and pancreatic cancer, prostate cancers with metastasis are also if more than one of the following things are there, the family history. So we have to check for the BRCA testing. Next slide, please. So these are the guidelines which are published in elsewhere. The same thing in NCCN. Next slide, please. So this is synthetic lethality. When there is a double strand repair defect, that is BRCA or HRD, when we block PARP inhibitor, which is a single strand repair mechanism, which leads to death of a cell. So this is called synthetic lethality, which is used clinically for the treatment of BRCA positive cancers. Next slide, please. Next slide. So these are the guidelines recommended for breast cancer and ovarian cancer. Ovarian cancer, germline BRCA, either a patient in the first line, if bevacizumab is exposed or not, if it is clinical complete response or partial response. So olaparib is a maintenance is indicated. It is a category 1 indication. We will see the studies in upcoming slides. And if bevacizumab is exposed in the first line, if it is BRCA unknown or BRCA mutation, so in both along with the bevacizumab, olaparib is indicated. It's a category 1 indication. Next slide, please. So it is for breast cancer, if it is hormone positive and HER2 negative, adjuvant endocrine therapy along with adjuvant endocrine therapy, olaparib is indicated if it is a germline BRCA mutation is positive, and there is a residual disease post first line. In hormone negative and HER2 negative disease also, adjuvant olaparib for 1 year if germline BRCA mutation is there, which is a category 1 indication. Next slide, please. In hormone positive, HER2 negative, this is the same thing. Next slide, please. So in metastatic unresectable diseases, germline BRCA mutation is positive, olaparib is a category 1 indication. Next slide. So in triple negative breast cancers, basically we test BRCA and PARP is a category 1 in first line itself. And in second line, if a mutation present, PARP inhibitors are category 1 indications. Next slide, please. This is a prostate cancer. Across all lines, for second and third, olaparib is indicated if the BRCA mutation is positive. Next slide, please. So this is the ASCO guidelines, which indicates PARP inhibitor in germline BRCA in first line, the first remission, that is maintenance after first line therapy or second or later line remissions. So maintenance olaparib can be used. We will see one by one all the studies. Next slide, please. Next. So this is the solo one study. Next slide, please. sorry, solo 2. Solo 2 is the maintenance of after post second line platinum sensitive relapse, BRCA1 mutation positive. This is the maintenance olaparib. It is compared with placebo. Next slide, please. So the PFS is 19.1 months versus 5.5 months against the placebo. So there is 4 times approximately. It is 4 times PFS. Next slide, please. So the thing is OS analysis, and it is 12.9 months with the maintenance olaparib benefit. The median OS is improved by 12.9 months. The hazard ratio is 0.75. So adjusted for subsequent PARP inhibitor use also the benefit is maintaining. Next slide, please. So olaparib significantly extended time to first subsequent therapy. So median OS is 27.4 versus 7.2. So next slide, please. The safety outcome analysis shows there is a MDS or AML in the olaparib arm, which is high in primary and final analysis. So that is the gravest adverse event. So NETA is around higher numbers. So the dose interruption is 45% against 18%. Next slide, please. So nausea and fatigue, asthenia and anemia, these are the most common side effects, and the neutropenia also, which is does not give any problem. So common patient used to have very low counts throughout the. Next slide, please. So olaparib-based placebo maintenance, it is after first line maintenance in advanced ovarian cancer in a BRCA1/2 mutated patient. Next slide. So the median PFS was 4.7 years. That is approximately 56 months versus 13.8 months against a placebo. This also again approximately it's 4 times. Next slide, please. So in OS analysis, 7 years approximately 67% of the patients were alive with olaparib and 47 patients were alive with placebo. So the curves are widely separating. Next slide, please. So the more favorable time to first subsequent therapy, that is 64 months versus 15.1 months, as well as second subsequent therapy, 93 months versus approximately 40 months with maintenance olaparib is placebo. So there's according to solo 1 and solo 2 is included in a category 1 indication after first line revision and second and third line revision. As a maintenance therapy. Next slide, please. So adverse events, again the same, the MDS AML is higher compared to placebo group. And grade 3 is also higher with olaparib, and I'm sorry, grade 3 is grade 3 is higher, and dose reduction in the interruption rate is higher with in olaparib. Next slide, please. So this is Paula 1 olaparib. It is also first line maintenance along with the bevacizumab. Next slide, please. So in this slide, we see olaparib and bevaci plus placebo versus bevaci. The median PFS is 46.8 months versus 17.6 months. So there is 59% reduction of disease progression or death. Hazard ratio is 0.41. Next slide, please. So there are they are categorized into intention to treatment, that is the whole population, and HRD positive, BRCA mutated, and HRD positive excluding BRCA mutated. So PS advantages was seen in HRD positive subjects with excluded BRCA mutation, as well as in subjects with included only BRCA mutation subjects. So across all arms, there was a bit. Next slide, please. So there was the OS final OS analysis. So adverse event, the MDS is also higher in the olaparib with the bevacizumab compared to placebo with bevacizumab. So new primary malignancies are also higher with the olaparib arm. So pneumonitis and bronchitis, ILD also. These are the things very common with severe severe adverse events, which are more in olaparib, not so common. Next slide, please. So maintenance of olaparib is a standard across first line after first line remission and second line remission. With Bevacizumab and HRD patients. So maintenance treatment in the platinum sensitive recurrent ovarian cancer independent from BRCA status. Next slide, please. Yeah, I will stop here. Thank you for listening.
Dr. Prasad, are you there?
Yes, sir. Yes, sir, please.
Yes.
I would, thank you, Dr. Panditharai. So that was quite a informative talk on how to get the maintenance treatment started for the next line treatment of patients. So may I now request Dr. Raja? Dr. Raja, are you there?
Sir, Dr. V. Arumugam is the next next speaker. Sorry for interrupting.
Armo sir, are you there? I was told that sir was driving.
Yes, yeah.
Oh,
Yeah, no,
wonderful.
I'm here only.
Okay, sir.
I'm done.
So thank you so much, Dr. Armo, for this for your presence. And I'd like to request you to start this topic on advances in the management of breast carcinomas. Over to you, Dr. Armo.
So, Yashik, you
Yeah.
will only present Dr. Armugam, or shall I ask Yashika to?
Yeah, you have to share the slides.
Okay. Madam, please
Okay.
share the screen.
Yeah, just a second. You can start, sir.
Yeah, okay. So, first of all, I thank the organizer for the opportunity and Dr. Prasad for the kind introduction of myself. And today's topic for discussion is advances in the management of breast cancer in 2024. So I think the discussion was on the basics of the slides which was sent to me is the basics of breast cancer and also the latest treatment with the PARP inhibitor and HER2 targeted therapy. But I think Dr. Prasanna is going to talk on the HER2 targeted therapy, so I have to skip that slides. So next slide. Yes, this is the breast cancer scenario, Indian scenario. It's about 28.8% of women diagnosed with the cancer have breast cancer, and 1 in 29 women have breast cancer, and 10.6% of cancer that is due to breast cancer, highest among all cancers. And 232,832 of women are likely to diagnose with the breast cancer by 2025. Next slide. So the breast cancer, the risk factors, we know that is increasing age and the genetic and family history, radiation exposure, dense breast tissue, obesity, alcohol consumption, gender, personal history of breast cancer, and early menarche and late menopause, and having first child at the elderly age, and never being pregnant under hormone therapy. These are the risk factors, everything we know that. And types of breast cancer, next slide. So types of breast cancer, it is invasive and non-invasive type. Invasive are DCIS and LCIS, and the invasive types, we know ductal carcinoma, lobular carcinoma, medullary carcinoma, tubular carcinoma, and other types. Next, we know the molecular subtypes, luminal A, B, and HER2 positive and triple negative, depending upon the ERPR and the HER2 status, and with the Ki67 index. Next slide. So about 15% of the breast cancer are considered as HER2 positive breast cancer, and HER2 gene amplification and or HER2 protein overexpression is linked to a more aggressive phenotype, and HER2 is a validated therapeutic target. Next slide. We know that how to interpret the HER2 positivity. It is HER0 score 0 and HER1 plus, 2 plus, and 3 plus, and the 2 plus we have to confirm with the FISH test. Next. So the innovation in the pathology and the molecular biology and the drug development have enabled HER2 positive breast cancer, a historically aggressive subtype, to become one with impressive outcome. And newer and novel therapeutic strategies have led to markedly improved the survival outcome, currently exceeding 90% in the HER2 positive early breast cancer treated with the chemotherapy and dual antibody therapy. So this is the approval of anti-HER2 therapy in the from the development to the current use. Next slide. So we can skip these slides because these are the topics are going to discuss by Dr. Prasanna. Next slide. Next slide. Next slide. Next slide. Next one. Next one. So we are going to talk with this PARP therapy. So what is the DNA repairing mechanism? We know what are the types of DNA damage. DNA damaging agents are DNA replication stress and the oxygen radicals and the polyaromatic hydrocarbon UV light and ionizing radiation chemotherapeutic drugs. And DNA damage types are base mismatches like insertion and deletion, and single strand DNA break, DNA adducts, double strand DNA breaks. And the repairing mechanisms are mismatch repairing and base excision repair and nucleotide excision repair and double strand DNA break repair. So the double strand DNA break repair is with the homologous recombination or no non-homologous end joining. Next. The role of PARP in the base excision repair of a single strand break in DNA. The PARP protein family characterized by structural resemblance and functional similarity consists of enzymes such as PARP1 and PARP2. And these proteins contains 2 ribose units and 2 phosphates per polymer unit. So specifically, PARP1 and PARP2 plays an important role in the DNA repair pathway called the base excision repair, addressing single strand DNA breaks. Next slide. So what happens if single strand repair fails? So single strand repair fails means it make the DNA go to a double strand break, and that will be repaired with the different repairing mechanism. Next, so the double strand break repairs, that is one is HRR. HRR is a high fidelity accurate pathway that restores the original DNA sequence by using matched DNA strand template for the repair process. And the non-homologous end-joining classical pathway is an error-prone repair pathway that repairs the loose ends of the broken DNA double helix by sealing them together with no mechanism to preserve the original DNA sequence at the site of damage. Next. Yeah, I already discussed. Next, yeah. So the both BRCA gene are tumor suppressor gene. So BRCA1 is located in chromosome 17 and BRCA2 is located in chromosome 13. That produces a protein that are usually by the cells in the enzymatic pathway that makes very precise and perfectly matched repairs to the DNA molecules that have double strand breaks. And the cancer risk caused by BRCA1 and BRCA2 mutations are inherited in a dominant fashion, even though usually only one mutated allele is directly inherited. So next slide. Yeah, so the association between the BRCA1 and BRCA2 with the associated cancers, the breast cancer risk with BRCA1 is 50 to 60% in female and male is 1.2%, and BRCA2 40 to 50% with the female breast cancer and male is up to 9%. The pancreatic cancer, BRCA1 is about 1 to 3% and BRCA2 2 to 7%. Ovarian cancer, 40 to 65% is associated with BRCA1 and 15 to 25% associated with BRCA2. And prostate cancer is 9% and versus 15%. Next. So the BRCA1 and 2 deficiency enables and accelerates carcinogenesis. The loss of BRCA1 and or BRCA2 creates a genomic instability and increased gain of function and loss of function events and selection of malignant behavior. Next. So what is the difference between the germline versus somatic? The somatic DNA changes occurred over a person lifetime in single cells and can lead to cancer and cannot be inherited. But the germline DNA damage is present in every cell of the body, including egg and sperm, and can increase cancer susceptibility and it can be inherited cancer. So somatic versus germline testing. Next slide. So all tumor contains DNA errors. So somatic testing, DNA is extracted from the tumor, and sometimes tumor proteins are studied instead of DNA. But in the germline testing, DNA is extracted from the blood or saliva to pick up the inherited genetic variants. Next slide. The HRD testing, the HRD can be assessed via the two different types of biomarkers. In the ovarian cancer, these include in individual mutations in the BRCA1 or BRCA2 and the assessment of genomic instability. So HRD testing, including LOH, LST, and TI, can inform prognosis and treatment decisions. Next slide. So this is the NCCN criteria for mutation testing in the breast, ovarian, and pancreatic cancer. So testing criteria for the high gene penetrance, high penetrance breast cancer susceptibility genes. So these are the guidelines we are following. Next slide. So the recommendations from the United States Preventive Service Task Force on who should be offered genetic testing for the BRCA mutation. 2 first-degree relatives with breast cancer, one of whom was diagnosed at age 50 or younger. A combination of 3 or more first or second-degree relatives with breast cancer, regardless of age or diagnosis. A combination of both breast and ovarian cancer among first and second-degree relatives. And the first-degree relatives with bilateral breast cancer, a combination of 2 or more first or second-degree relatives with ovarian cancer, regardless of age or diagnosis. A first and or second-degree relatives with both breast and ovarian cancer at any age, and history of breast cancer with the male relatives. So these are the recommendations of BRCA mutations. So clinical practice guidelines for BRCA 1 and 2. Next slide. So this is, next slide, please. Yeah, so this is, we have to go through this, where we have to, as clinical practical guidelines for the BRCA1 and BRCA2 testing. The next is synthetic lethality. And next slide. And next slide. Yeah, so the homologous recombinant deficiency or deficiency positivity distribution in the breast cancer, that is data confirmed the feasibility and reliability of this novel HRD assessment system. And it suggested that more breast cancer patients, especially triple negative breast cancer subtypes, should undergo HRD screening for sufficient assessment and better therapeutic options. So next slide. So targeted therapy for the breast cancer, how we are treating patients with CDK4/6 inhibitor or PIK3CA mutations and PI3K inhibitor and the other TKAs. So this is the flow chart we are following. So next slide. Next slide. Next slide. Yeah, so the possible association between BRCA mutation and aggressive disease phenotype. The following three aspects of disease phenotype are more frequently associated with the germline BRCA mutation than wild BRCA type. So the tumors with the germline BRCA2 mutations are also more likely to show a pattern of intraductal carcinoma, which correlates with poor prognosis. Next slide. Next slide. So this is the NCCN guidelines. Adjuvant systemic therapy after preoperative systemic therapy when the patient with HR positive and HER2 negative. So YPT0 T0, N0 or PCR adjuvant endocrine therapy is recommended as a category 1 if the patient has a residual disease with a pathological stage T1 to 4N0 adjuvant endocrine therapy with adjuvant olaparib if germline BRCA mutation is positive. And select patients may be eligible for adjuvant abemaciclib also. So in the HR negative and HER2 negative patients, that is triple negative patients, after preoperative systemic therapy, the pathology, if the patient achieved PCR for high risk, adjuvant pembrolizumab can be used if the pembrolizumab containing regimen was given preoperatively. So after neoadjuvant chemotherapy in a triple negative breast cancer, if the pathological stage T1 to 4 N0 are node positive, adjuvant pembrolizumab, if pembrolizumab containing regimen was given preoperatively, or adjuvant capecitabine 6 to 8 cycles, or adjuvant olaparib 1 year if the germline BRCA mutation is positive. It's a category 1 recommendation. Next. So the patient received a preoperative or adjuvant regimen. The regimen listed in the table is a HER2 negative disease. All are category 1, except where indicated when used as the adjuvant setting. So olaparib, if recommended in a HER2 negative patients with if the germline BRCA1 and 2 mutation is positive. Next. So systemic therapy regimen for the recurrent and unresectable or stage 4 metastatic disease, the HR positive, HER2 negative with the visceral crisis, or the endocrine refractory patient, the first line recommendation is if there is no BRCA mutation, you can go for systemic therapy. If there is a germline BRCA mutation, we can go with the PARP inhibitor, either olaparib or talazoparib. Next. So systemic therapy regimen for recurrent and metastatic disease with the HR negative and HER2 negative, so triple negative breast cancer. The first line recommendation is if the PDL1 CPS score more than or equal to 10, regardless of the germline BRCA mutation, can go with the pembro plus chemo. If the PDL1 score is less than 10, no germline mutation, you can go with the systemic therapy. If the PDL1 score is less than 10, but the germline mutation is positive, then we'll go with the PARP inhibitor. Category 1 is preferred, or with the platinum based chemo. And in the second line, germline BRCA1 and 2 mutation positive, then we can go with the PARP inhibitor, either olaparib or talazoparib. So this is the ASCO guidelines, the PARP inhibitors in the management of ovarian cancer. So PARP inhibitor, the first line, first remission, there is a maintenance with germline BRCA mutation positive. You can go with olaparib, or in the olaparib combination with the bevacizumab, or either niraparib or rucaparib is also recommended. Thank you.
Thank you so much, Dr. Marwaham, for those updates on the breast cancer. Now I would like to invite Dr. Prasanna. Dr. Prasanna, are you there?
Yeah, good evening, Prasad.
Hi, Prasanna.
Good evening.
Over to you, Prasanna.
Yeah,
Stage
sure.
is yours.
Yashika madam, can you please share the slides?
No, I'll just. I'll
You're
try.
sir. Okay, sir. Okay, sir.
Can you see the screen?
No, sir, in the screen.
Just.
Sir, we are able to see your screen. Can
Yeah.
you please share your slides?
Yeah. Yeah. Now it is good.
Yes, sir, you are good to go.
Yes, sir.
Yeah. Thank you, Prasad, for giving this opportunity to talk about breast malignancy this evening. So today I'll be touching upon the HER2 breast cancer, the newer advances up to 2024. So without much ado, let's go into the topic. So I think Dr. Armugam, the same slide that Dr. Armugam has been given, I think, right? So breast cancer, we know that 28% of Indian women has been diagnosed with breast cancer, and it is being alarmingly increasing. And India, 1 in 29 women have breast cancer today. And it also the leading cause of death, especially to be 2025, and at least 10% of cancer deaths is due to breast cancer. So risk factors, I will not go into it in detail. Yes, as we know that the molecular subtype is the newer norm. The luminal breast cancer, HER2 positive and triple negative breast cancer. Here the luminal breast cancer, the median survival is at least more than 5 years. And now in HER2 positive metastatic breast cancer also, we are able to achieve at par with the luminal breast cancer subtype. So in Western world, 15% of breast cancers are HER2 positive, but in India, we see a lot of HER2 positive breast cancer, 25 to 30%. And it's typically a HER2 enriched breast cancer, which is a more aggressive subtype, and also HER2 is a validated therapeutic target. So again, it is divided into two. One is the hormone receptor negative HER2 breast cancer and triple positive breast cancer. So this is the classical binary classification of HER2 positive breast cancer. HER2 3+ score is the standardized option for usage of anti-HER2 therapies, whereas HER2 1+ and HER2 2+ FISH negative mounts to HER2 low breast cancer. So this is again what we see a lot today. HER2 low breast cancers, again a potential target when it comes to an advanced breast cancer. And HER2 positive breast cancer is today HER2 IHC3+. Today we are going to focus on it. So, and let us start from early breast cancer, HER2 positive. Yes, there is an option of neoadjuvant therapy whenever a patient presents with the tumor size of more than 2 centimeter. So now it has been the standard of care in HER2 positive breast cancer for the patient more than 2 centimeter tumor size. So the advantages or benefits of neoadjuvant therapy is to optimize the surgical approach and to identify new biomarkers for response and resistance, and also for early initiation of systemic therapy, because we know breast cancer is a systemic disease, and also to prognosticate the disease and to risk stratify them. This is also beneficial, and to modify the stratification or to the escalation and de-escalation protocols can be applied, and also for the testing of new drugs. So by reducing the tumor size, we are able to increase the resectability and breast conservation rates, and also reduces the need of revision for revised residual tumor. And as I said, the response adjusted therapy or adapted therapy can be tried depending upon the PCR rates. And PCR, as I said, is the most favorable outcome, especially in HER2 positive and triple negative breast cancer. And downstaging of axilla in a limited node positive breast cancer patient can occur. So PCR is now a strong surrogate endpoint of event-free survival and overall survival when it comes to HER2 positive breast cancer, early breast cancer. So we are trying to move the bar on PCR nowadays. So this is the classical Neosphere and Trafina study. We follow the Trafina study, especially TCHP has now been standard of care in the neoadjuvant setting, especially in early the HER2 positive breast cancer. And the advantage is again the doubling of the PCR rates when you combine pertuzumab along with the TCH chemotherapy backbone, and it is just 63% when if we don't use pertuzumab, then the response rate is less than 50%. So the PCR rates also better when you combine pertuzumab along with the TC backbone. So this is the new norms that we follow. So the newly diagnosed early breast cancer, HER2 positive, so give a neoadjuvant therapy of 6 cycles, and you assess the pathological complete response. If the pathological complete response achieved no change in therapy, so but when you have residual disease, that is especially at least 40% of these patients can have a residual disease and evidence of disease in both breast or axilla, you escalate the protocol to another HER2 target, that is TDM1. So this is the proposed strategy or current strategy of early breast cancer HER2 positive. TCHP now has become the standard neoadjuvant, and as I said, the residual disease, if it is present, you go with TDM1 of 14 cycles. If the patient has achieved a PCR, then you go with the maintenance anti-HER2 therapy, either Herceptin or you add pertuzumab if patient is not positive. So these are all future directions or clinical trials in early breast cancer. So I will not touch upon. Let us move to the metastatic breast cancer. So HER2 positive metastatic breast cancer, as I mentioned, the median survival is 50 months. It is at par with a hormone receptor positive breast cancer. So now with the newer targets being improved in anti-HER2 therapy, we are able to now achieve at least 50 months overall or median survival rates at par with the luminal A or B positive breast cancer. And triple negative breast cancer, we are only able to achieve just 15 months overall median survival. So I'll be just touching upon my favorite ABC guidelines. These are latest ABC 7 guidelines being published 2024 in the Breast Journal. So as we all know, ABC is the international consensus conference for advanced breast cancer, once in every 2 years, conglomerated in the Portugal, Lisbon. And this is the 7th ABC guidelines, and this year would be the ABC 8 in 2025 November. So this is the diagnostic workup, what they recommend in ABC guidelines. We go with germinal BRCA1, BRCA2 as usual for all HER2 negative patients, but for HER2 positive patients, we don't venture into BRCA-ness. So biopsy with metastatic lesion is always recommended whenever the patient had recurrence or even in the de novo metastasis. And a minimal staging workup, especially the PET-CT, is the order of the day. And yes, we have highly potential targets when it comes to the HER2 therapy. In 1987, it was found that HER2 was associated with poor outcomes. So trastuzumab was the first game changer in 1998 or early 2000s. And then oral HER2 blocker was identified in 2007, lapatinib. And then in 2012, we had pertuzumab being approved as a first-line therapy in advanced breast cancer. And trastuzumab emtansine, that is TDM1, was approved in 2013. And now we have fewer molecules also, especially newer molecules. We have 2022, we have TDXD, and also oral therapies of pacatinib and neratinib has been now approved as second line and third line. And we have now antibody drug conjugates like margetuximab being approved in the third line. So all these things becomes, it's a fascination for HER2 therapy usage in advanced breast cancer nowadays. And we have come a long way, especially over the past 2 decades. So HER2 positive metastatic breast cancer is an aggressive natural history. As I said, it is having a short PFS, and the median overall survival was just less than 2 years without all these anti-HER2 therapy. So prior to the anti-HER2 therapy or targeted therapy, the median overall survival of a HER2 positive advanced breast cancer is less than 2 years. So there was a major improvement in anti-HER2 therapy over the last 2 decades, so which prolonged the median overall survival to at least more than 5 years. So currently, as I said, the overall survival is at par with the luminal breast cancer patient. So trastuzumab is again the game changer, which was FDA approved in 1998. We know that the addition of pertuzumab to trastuzumab has now become the order of the day for advanced breast cancer, which improved the overall response rate, PFS, and OS, and has now become the standard first-line therapy. And when it comes to the triple positive breast cancer, you can always maintain them with the maintenance endocrine therapy after the cytotoxic chemotherapy in combination with the dual HER2 blocker. So there is always a state of vacuum for a second line HER2 breast cancer, especially when it comes to the second line. We have potential targets like trastuzumab deruxtecan. So TDXD has now become the standard of care as a second line therapy in HER2 metastatic breast cancer. This is the Destiny Breast 03 study. It was compared with the TDM1, which was the standard second line 10 years ago, probably. So TDXD was compared with TDM1, and the primary endpoint was PFS, and secondary endpoint was OS. And these patients had brain metastasis, and also the patients had 70% of patients had visceral metastasis. So brain metastasis, 23% of patients had active brain metastasis in TDXD arm. So this study showed a benefit of both PFS and overall survival in second-line TDXD, and the median PFS was 29 months versus 7 months with the TDM1 arm, and 52 months with the overall survival with 3DXD versus 42 months. This is typically of 10-month benefit of overall survival in the second-line TDXD arm. So this was quite a commendable result. And there is now a new kid in the block, tucatinib, still not available in India, but still HER2 Climb 02 study, TDM1 along with tucatinib versus TDM1 with placebo. So these patients also, there are a considerable amount of brain metastasis patients, and tucatinib fared well with brain metastasis, especially the PFS of 7.8 months versus 5.7 months in the TDM1 arm. So whenever a patient has a brain metastasis with triple HER2 positive metastatic breast cancer, so there is an option of adding tucatinib with that is a small molecule inhibitor with a TDM1 antibody drug conjugate. So what about most of our Indian patients, they due to financial reasons, they forgo TDXD, especially in the second line. So we will be able to give only TDM1 in the second line option as a advanced breast cancer regimen. So what about in third line? So this has been answered in a study, Destiny Breast 02 study, TDXD versus treatment of physician's choice, whether it can be a lapatinib with capecitabine. Most common we use as a all oral therapy in our clinic. So there are again key endpoints. PFS and OS has been assessed, and this study also showed a good PFS benefit even when TDXD is used as a third line option. So 16 months PFS versus 5.5. So nearly more than 10 months difference in PFS. And also there is a significant improvement in the overall survival also. So the median overall survival of 35 months versus 25 months with the treatment of physician's choice. Again, 10 months advantage in the overall survival. So the lesson learned is both PFS and overall survival benefit still exist when you use a TDXD in the third line regimen in HER2 positive advanced breast cancer. Especially this fits into the Indian scenario. And again, this was presented in ESMO Breast 2024 last year. So this is a comparison between the TDXD, whether you can use it in second line or third line. Yes, it is ideal to use this as second line, but whenever there is a financial constraint or patient doesn't need to spend a lot on the early phases, then you always choose a TDXD in the third line also. So there is at least 10 months difference, as I said. So you can also employ TDXD in the third line regimen. This is a lesson that we have learned. So what is beyond third line or beyond third line and beyond? So tucatinib, again, a new kid in the block. This was studied. So this is tucatinib with trastuzumab with capecitabine. So again, well tolerable regimen versus trastuzumab with capecitabine has been studied, and this also patients included with brain metastasis also. So treated brain metastasis and also asymptomatic brain metastasis also been included in the study. And progression-free survival was beneficial, especially when it comes to over 1 month. It was 33 months, 33% PFS versus 12% PFS over the period of 12 months. And overall survival was again 2-year OS benefit was 45% nearly in tucatinib versus 26% in the placebo. So when you add a small molecule HER2 along with a backbone of trastuzumab with capecitabine, especially in the advanced third line state, still you can achieve a reasonable overall survival benefit. So this is again different agents being studied in the third line and beyond setting. One is the SOPHIA trial, as I said, margetuximab antibody drug conjugate has been studied, and which showed a very marginal benefit in median PFS, 5.8 months versus 4.9 months when compared to the trastuzumab chemotherapy arm. Neratinib, again, another small molecule HER2 TKI with the NALA trial, again shows a promise. Pyrotinib has a lot of side effects, especially when it comes to diarrhea. So probably pyrotinib would be abandoned soon. So FORB trial has again very marginal benefit with all oral therapy in clinic. So this is the comprehensive summary of HER2 positive advanced breast cancer. This is again ABC7 guidelines. So whenever a patient is suitable for chemotherapy, yes, you initiate a chemotherapy backbone with pertuzumab and trastuzumab. The most common is TCHP or THP, and maintain the anti-HER2 as a maintenance therapy. And second line option, always TDXD is a optimal second line option. When it is not available or not feasible due to financial reason, we go with TDM1. And on progression as a third line, always have an option of TDXD. So Destiny Breast 02 trial with the overall survival advantage of 10 months. You can use it as a third line TDXD benefit. And previously unused, like all, if the patient needs an all oral therapy, then you can go with tucatinib with capecitabine. So if you prefer it, especially in the patient has a brain metastasis. So as a third line and beyond. So we have a first line sorted out, second line sorted out, and we have third line. So ideally, the patient would be managed at least for 4 to 5 years with a median overall survival. So this is the proposed strategy of what we are speaking about. So TDXD is an ideal second line option. Then there are other options like lapatinib capecitabine, and very potential option in our clinic. And tucatinib is still again not available, but still we can go ahead when compared to the as a third line setup, especially in brain metastasis. And margetuximab shows promise. So when it comes to the CNS disease, as I said, HER2 climb is a good PFS benefit, especially a PFS of at least 9.6 months with the median overall survival of 21 months when you add tucatinib with trastuzumab and capecitabine backbone. And NALA trial also has promise in CNS disease. And as I said, TDXT crosses the blood-brain barrier, and hence the breast 3 Destiny trial showed a very positive PFS benefit when it comes to the CNS disease performance. These are future directions of HER2 positive breast cancer with brain metastasis. So this trial is going to be published very soon, HER2 brain trial. So probably this will throw some light on the usage of oral TKIs along with backbone of taxane with Herceptin with pertuzumab versus all these oral TKIs. So we'll wait for the results. So these are all the adverse event we'll encounter in our day-to-day practice when we administer anti-HER2 therapy. So TDXT, as most of us will know, that it's like a hematotoxicity, more likely to damage the bone marrow. So and also pneumonitis is most commonly encountered. So all these oral therapies, diarrhea especially is more common with lapatinib, and also even with pyrotinib, diarrhea is more common, and also the skin rashes is more common with lapatinib and also the tupatinib. So, so thank you for your patient listening. Thank you.
Thank you, Prasanna. Thank you for the wonderful update on HER2 positive breast cancer. So next would be the topic, which would be which was requested by Dr. Raja, but I think he got an emergency and he had to leave. So I would like to go ahead with his presentation. I hope my screen is visible. So this would be the last presentation for the day, which would be on the management of recurrent ovarian carcinoma. So we do have this agenda for this particular presentation for the next 10 minutes. So what exactly is the ovarian carcinoma? We do have this biochemical recurrence, which can define the biochemical recurrence. So do we need to really wait for the treatment, or should we go ahead with treating the disease? So there had been a lot of confusion regarding the treatment of biochemical recurrence, whether to really treat or wait. So these were all addressed in this study by the EORTC 55955, as well as the Wong et al. Study, which had been published in the Journal of Ovarian Cancer in 2013. So there had been a lot of debate whether to start on with the treatment or should we really wait. So the EVA-RTC study, which was published in 2010, a decade ago, had shown that in the absence of radiographic or clinical findings, labeling biochemical recurrence can result in artificially shortening the platinum-free interval and causing some patients to be inappropriately labeled as platinum resistant. So most of the time, what had been in the clinical practice is that with just only the rise in CA 125, patients are either put on only cytotoxic medications or they're just followed up with radiological evaluations, and no cytotoxic drugs are added in their treatment at that point of time. So what do we need to do? So after an increase in the CA 125 values, the median time to clinical relapse generally happens between about 2 to 6 months. So should we really use an immediate treatment, which is early treatment? Again, NCCN is also divided between starting the treatment early or starting with any of the cytostatic agents. So as of now, it is noted that we have a very limited evidence for starting an immediate treatment, but it has to be decided on a case to case basis before we decide on whether to treat or to wait. But what exactly are we looking at the treatment goals when we are looking at ovarian recurrence? So relapse disease are usually generally incurable, and goals of the treatment should be mainly to prolong the survival, delay the disease progression, control disease related symptoms, at the same time minimize the treatment related side effects with an improved quality of life. So a lot of factors which would impact the treatment for recurrent ovarian carcinoma, which would be tumor biology or histology, the platinum-free interval, the number of previous regimens which were initially done, toxicity from the previous therapy, which would be including the use of the growth factors, blood transfusion, taxane-induced neuropathy. The volume and the site of disease definitely matters. The symptomatic patients, which would lead to treatment urgency, performance status, quality of life, and of course the patient preference as such. So when we are looking at the management of platinum sensitive ovarian recurrent malignancy, we have divided between either to choose for a secondary cytoreductive surgery or second-line chemotherapy. So there are a lot of studies which had been evaluated with doublet and re-exposing the same paclitaxel carboplatin or starting on with carboplatin gemcitabine or using carboplatin with pegylated liposomal doxorubicin. All these trials had shown that there has been an improvement in the progression-free survival, but there had not been any much significant in the overall survival except for the taxanes. So more or less, we do have the standard options of either taxane, gemcitabine, or liposomal doxorubicin, which can be combined with carboplatin. Along with that, we could also look at the use of bevacizumab as maintenance treatment. So there are also study designs which had evaluated the use of topotecan also. So how exactly are we going to choose any of those regimes in the recurrent ovarian carcinoma for these patients? So, for example, patients who have a residual neuropathy and who do have a strong preference to retain the hair because when they do not want to have alopecia, we could look at the possibility of using gemcitabine or pegylated liposomal doxorubicin. So, pegylated liposomal doxorubicin plus carboplatin has lesser neutropenia, lesser neurotoxicity, alopecia, but it has more of hand-foot syndrome, mucositis, and thrombocytopenia. Whereas when you're looking at gemcitabine carboplatin, it produces a lot of thrombocytopenia and more of hematological complications. So how do we choose between carboplatin versus cisplatin? Again, we could use, but at least for convenience sake, most of us would prefer choosing carboplatin instead of cisplatin because of nephrotoxicity and the prolonged hydration which would be required for cisplatin. So these are the various trials which had evaluated the different combinations, and all these studies have had shown that it is better to use a doublet combination whenever or wherever possible. So when you are looking at the meta-analysis by the Cochrane, we could see that pegylated liposomal doxorubicin is a little more effective than paclitaxel carboplatin, and it is better tolerated, and ideally it should be considered as a first-line treatment. But unfortunately, it could cause more anemia and thrombocytopenia, and we need to weigh the risks and benefits and side effects before we choose a regimen. When we are looking at a platinum-resistant relapse, pegylated liposomal doxorubicin as a single agent is also good enough, but again, we need to be very cautious when we are using it, depending upon the dosage and the patient profile before we choose this particular drug. So when you're looking at the secondary cytoreductive surgery, there are a lot of trials which had evaluated the secondary cytoreductive surgery, like the desktop 3, COG 213, SOC1, soccer trial, and the Lorascon. So all these had shown that the overall survival benefit and the progression-free survival benefit had been exclusively seen in the platinum-sensitive recurrent ovarian carcinoma with a better AGO score and a patient who would be able to have a complete R0 resection. So these are all the study design which had looked at using the secondary cytoreductive surgery as a treatment option. But again, it's an individualized and the institutional based treatment depending upon the surgical as well as the medical oncology collaborative tumor board decision. So overall, we could look at the possibility of starting with the chemotherapy or with along with bevacizumab, and those patients who would have a residual disease can be definitely be considered for a secondary cytoreductive surgery. So these are all the different trials which had been compared in US, Germany, as well as in China. But again, with the exceptional OS rate with a median of 64 months for chemotherapy and the bevacizumab arm, unfortunately, there was no improvement in the overall survival arm. Again, complete cytoreductive surgery followed by a systemic treatment. It improves the progression-free survival and extends the benefit to the next line of treatment in selected patients who had the first recurrence. And again, complete cytoreductive surgery in the second or the later recurrence still may provide benefit in selected patients, especially with the specialized centers with the availability of gynaecologists. So overall, secondary cytoreductive surgery followed by chemotherapy should be considered, but again, it needs to be individualized and institutional based treatment, which would decide on the treatment plan. So coming to the role of HIPEC, again, adding HIPEC to cytoreductive surgery had not been proven to be beneficial, but in It was not evaluated as a multiple RCT in the secondary recurrent setting. So there are certain studies which had shown it was one of the studies which was published in 120 women who were randomized with HIPEC or without HIPEC. This study, though the sample size was less, it had shown to have a significant survival benefit, and maximum efficacy was seen only in those patients who had a low PCI index as well as CC0 after surgery. So these are the study designs which had shown which would be the better drug. Again, we could see that HIPEC with carboplatin was tolerated, but did not result in superior clinical outcome. So this study doesn't support the use of HIPEC with carboplatin during cytoreductive surgery. So we need to be very careful in choosing the agent which we would use for HIPEC as well. Now coming to the platinum resistant recurrent ovarian carcinoma, where there's progression which happens within 4 weeks of completing the first line platinum based treatment, we put them as platinum refractory. And when the resistant and then the recurrence happens within 6 months of the first line platinum based treatment, it is called as platinum resistant. But again, we do not have any benefit with the combination treatment with platinum resistant ovarian carcinoma. The progression free survival was not increased. Unfortunately, the toxicity was more. So, in this particular group of combination, ideally a single agent would be the better modality. So, we could use as a sequential single agent therapy for the patients who had uh, platinum refractory or platinum resistant disease. So when we are looking at the response rate, we are looking at regulated liposomal doxorubicin, docetaxel, weekly Paclitaxel, gem, oral etoposide, and topotecan, with the response rates varying between about 20 to 27%. So overall, can platinum be re-challenged in this ovarian carcinoma? There are a lot of studies which were evaluated, but unfortunately, platinum did not really benefit many of these particular group of patients. So that's when we do have the knowledge of the BRCA in the patients with ovarian carcinomas, and we are looking at using either niraparib, olaparib, rucaparib as second line or beyond the second line treatment in the ovarian recurrent setting. And now, with the understanding of more and more of the immunotherapy options, those patients who have MSI high or deficient MMR or a high tumor mutation burden of more than 10 mutation per megabase without any major treatment options, we could look at the option of using pembrolizumab or dostarlimab. So these are the newer treatment options for patients who will be eligible for second line or subsequent line of treatment. So overall, when we are looking at the treatment options, we do have the options of single agent, doublet, PARP inhibitors, as well as the hormonal agents also the treatment of recurrent ovarian carcinoma. So overall, when we are looking at the summary, generally recurrent ovarian cancers are incurable, but we do need to understand the platinum sensitivity and the platinum free interval before we label a patient as platinum sensitive, platinum refractory, or platinum resistant. We need to choose the right patient for the secondary cytoreductive surgery because the patient needs to be the ideal patient who would benefit with the major surgery, and probably the role of HIPEC with the secondary cytoreductive surgery has to be chosen in a place where there is expertise. The second line chemotherapy currently is all based on the treatment free interval. And the major concern when we are treating a platinum resistant or a refractory ovarian carcinoma is that they do not respond well. Single agent are the best treatment options. Quality of life, and these patients has to be treated with minimal toxicity. Biological agents, again in the second line, third line, or beyond the third line setting, had shown to have a significant improvement in the survival in terms of PFS, but they do not have any OS advantage. Newer treatment options like margaretiximab all coming up with the invention of molecular biology. We might be able to get better drugs in the future. Thank you so much for the patient listening. And I would like to thank Glenmark for helping us with this interactive session. And is there any questions? I'll be happy to have all the panelists have an interaction. Any questions, please? So if there are no further questions, Yashika?
Yes, sir. Thank you to all the speakers and also Dr. Prasad for organizing this conference. And at last, thank you to the Glenmark team for all the support. So if there are no further questions, we can close the meeting, sir.
So thank you all the speakers. Thank you, Glenmark, and
Thank you,
thanks
sir.
everyone for this interactive evening. Thanks a lot. Good
Okay,
night.
support team, please close the meeting.